welcome back. Today we are going to talk about anti-tubercular agents. So for a quick recap, we started with anti-infective agents, and in that this is a subtopic, that is anti-tubercular agents. So in anti-infective agents we have already covered local anti-infective agents, preservatives, antifungal agents, UTI anti-infective agents. So if you have not checked it out, please go check it out. So today we will start with anti-tubercular agents. First and foremost, what is tuberculosis? So tuberculosis is a chronic infectious granulomatous disease caused by Mycobacterium tuberculosis. So it primarily affects the lungs, and then it can go to other organs as well. So depending on the site of infection, the disease can be categorized as the following. First we have pulmonary tuberculosis. Pulmonary tuberculosis when it affects the respiratory tract. Next we have genitourinary tuberculosis when it affects the genitourinary tract. Then tuberculous meningitis when it affects the meninges, that is the nervous system. And miliary TB when it is widespread. Miliary because of the millet size. So it is very small and it reaches all the parts of the body. So we'll call it miliary tuberculosis. Signs and symptoms. So in the signs and symptoms, it includes hemoptysis, that is vomiting blood. That is, now there is a difference between hemoptysis and hematemesis. Hemoptysis, it means that it is coming from the respiratory tract, whereas hematemesis is when it is coming from the stomach. So in tuberculosis, the major clinical feature is hemoptysis. Next we have weight loss. So there would be very extreme weight loss, that is more than 10 kgs in a month, and the patient will look very fragile and very weak. Now this disease was also earlier known as the muscle wasting disease because there is a lot of muscle loss. Next we have night sweats. This is also a very characteristic symptom of tuberculosis. Then we have muscle wasting, as I said earlier, and fever. So what are anti-tubercular drugs? Anti-tubercular drugs are the agents which act against M. tuberculosis, and they can be used in the treatment and the prevention of tuberculosis. Now for the classification of anti-tubercular drugs, we have two classes. The first is first line drugs and the second one is the second line drugs. Now what is the difference between first line and second line drugs is the first line drugs are more commonly used. They are more commonly used and they are less toxic. Along with that, they have a very less side effect profile. Whereas the second line drugs, they are rarely used. They are toxic and they have a greater side effect profile. Now we call upon the second line drugs only when there is a drug resistant TB. So when there are drug resistant TBs, we prefer the second line drugs. Otherwise the first line drugs are sufficient. Now how to remember the first line and the second line drug? There is an acronym which we have made, that is RIPE. RIPE means rifampicin, isoniazid, pyrazinamide, ethambutol. Whereas the second line drugs is FACEPAC, that is FACEPAC. So FACEPAC, F is fluoroquinolones, A is aminoglycosides, C would be cycloserine, ethionamide, para-aminosalicylic acid, and C would be capreomycin. So in fluoroquinolones, we can name all the fluoroquinolones like ciprofloxacin, moxifloxacin, gatifloxacin, ofloxacin, levofloxacin. Whereas aminoglycosides, gentamicin, kanamycin, capreomycin, amikacin, streptomycin. Others will include cycloserine, ethionamide, para-aminosalicylic acid, and capreomycin. Now there is another classification based on the activity of the drug, that is whether it is bactericidal or bacteriostatic. And as I had said earlier, the first line and the second line drugs, we have some standard drugs and we have some reserve drugs. So in standard drugs, we have bactericidal and bacteriostatic drugs. In bactericidal drugs, we have isonicotinic acid hydrozide, that is INH. This is also known as isoniazid. Next we have rifampicin. streptomycin, and pyrazinamide. In bacteriostatic drugs, we have ethambutol and thiacetazone. In bactericidal drugs, we have capreomycin, kanamycin, and the fluoroquinolones. Whereas in bacteriostatic, we have ethionamide, cycloserine, and para-amino salicylic acid. Next, going on to the first drug, that is isoniazid. Isoniazid is also known as INH. Now, what is the full form of INH? Isonicotinic acid hydrazide. So, it is also known as isonicotinic acid hydrazide. Now, what is the mechanism of action? It inhibits mycolic acid synthesis, which is a part of the mycobacterium cell wall. Therefore, synthesis of the cell wall is disrupted. So, what will happen is this mycolic acid is the building blocks of the Mycobacterium tuberculosis. So mycobacterium because it has mycolic acid. Now if this integral part of the cell wall is inhibited, synthesis is inhibited, then the cell wall is disrupted, and because of the cell wall disruption there would be death of the bacteria. Next we have the side effect profile. So it is hepatotoxic. It causes hepatotoxicity, that is increased or LFT derangement. Then vitamin B6 deficiency, that is pyridoxine deficiency. Peripheral neuritis, neuronal toxicity. In neuronal toxicity, we'll see mental disturbances, confusion. Then it will also cause metabolic acidosis and hepatitis. Now, most of the anti-tubercular drugs are notorious to cause hepatitis. So, if any ATR is asked, you can always go for hepatotoxicity and hepatitis. Next is the uses. So it is used only in tuberculosis. Now let us go to the structure. As the name suggests, isonicotinic acid hydrazide. So first we'll see what is nicotinic acid. So nicotinic acid is a pyridine ring along with a COOH carboxylic acid group here. So this is our nicotinic acid. Now if we go for isonicotinic acid, thus this one right here, the position of COH will be changed to here. So this is our isonicotinic acid. Now the name is not only isonicotinic acid, it is isonicotinic acid hydrazide. So how do we write hydrazide? Hydrazide is NH to NH2. So this is a hydrazide. So this group will be attached to this one right here. So we will get, first we will draw our base, that is a pyridine ring. Then we will add our nicotinic acid. Isonicotinic means it is C double bond O. Now we will replace this OH group with NH2 NH2. So we will make an NH and a NH2. This is our isonicotinic acid hydrazide, also known as isoniazid. Next we have the synthesis of isoniazid. So for the synthesis of an isoniazid, we will take 4-methylpyridine. This is oxidized in the presence of KMNO4 to get isonicotinic acid. So we'll take a methyl. So this is the fourth position. 1, 2, 3, 4. So 4-methylpyridine, and we will oxidize it. So after oxidizing it, we will get isonicotinic acid. So on heating isonicotinic acid in the presence of anhydrous hydrazide, we will get INH. That is, first we will treat it with ethanol and sulfuric acid. So this H group is replaced with C2H5. Here there would be removal of water, and this group will be added here, ethyl group. So next is this ethyl group along with one oxygen will be replaced with this one right here. So we will get CONH NH2. So isonicotinic acid is reacted in the presence of ethanol and sulfuric acid to get a isonicotinic acid with a C2H5 group. Then hydrazide is added, that is anhydrous hydrazide, and we will get isoniazid. Next we have ethambutol. So we'll break the word eth, but, all. So first we'll draw eth. It is CH attached to another CH. 1, 2, 3, 2 here, 2 here. Now eth done. Eth done. Means amino group. So NH group. Next we have but. But means 4 carbon. So instead of writing the 4 carbons in one line, we will write it this way. 1, 2, 3, 4. Same thing here. 1, 2, 3, 4. This would be CH3, this would be CH2, this will be CH, this also will be CH2, 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 CH3, and all. So we give a OH group right here. So this is a structure of ethambutol. So what is the mechanism of action? It will inhibit arabinosyl transferase enzyme, which is important in the formation of arabinogalactone synthesis. So now this arabinogalactone, this polymer, is responsible for the cell wall stability. So if there is no cell wall stability, they will disrupt the cell wall. Now the side effects include hepatotoxicity. As I said, everywhere you can stick hepatotoxicity. Now specific to ethambutol, there would be a rash, fever, and optic neuritis. So you have to remember, optic neuritis is the major adverse effect of ethambutol. So whenever you give ethambutol, you have to go for optic function test every 2 months. Next we have pyrazinamide. So for pyrazinamide, we will take pyrazine and then amide. How do we draw pyrazine? A pyrazine is a benzene ring with opposite nitrogen atoms and double bonds in the ring, and amide is C double bond O NH2. So we will combine this both and we will add pyrazinamide would be a pyrazine ring and then amide, so C double bond O and H2. So this is a pyrazinamide. So pyrazinamide will get converted to pyrazinoic acid by the enzyme pyrazine amidase. Now since it's a pyrazine and amide, so to break down the pyrazine amide, we have pyrazine amide ase. So this pyrazinoic acid will get accumulated now in the cells, and then it will inhibit the mycolic acid synthesis, and it will eventually disrupt the cell wall. Next, the side effects are hepatotoxicity and hyperuricemia. So the most important side effect of pyrazinamide is hyperuricemia. Next we have rifampicin. Now rifampicin is a semi-synthetic anti-TB drug derived from rifamycin B. Now this rifamycin B, this compound is obtained from the bacteria Streptomyces. The MOA is it inhibits RNA synthesis by binding to the beta subunit of DNA dependent RNA polymerase. Now how can we remember this? Rifa, remember R, so it will inhibit DNA dependent RNA polymerase. So rifampicin, and it will inhibit RNA synthesis. Now the side effect is hepatotoxicity, hepatitis, and it also causes a very peculiar orange-red discoloration of the urine and other secretions. So if the patient sweats, the color would be orange to red. Urine, most frequently we can see a yellow or red discoloration. Next we have uses. Now rifampicin is used widely in tuberculosis, leprosy. It's a second or third drug of choice in MRSA, that is methicillin-resistant Staphylococcus aureus infections, Legionella infection, and brucellosis. Next we have the second line drugs. So in the second line drugs, we have the first drug, that is para-amino-salicylic acid. Now how do we remember para-amino-salicylic acid? That is PASA. So first we will draw our salicylic acid. So salicylic acid is, in the first position we'll draw COOH, in the second we'll draw OH. Now it means, it says para-amino-salicylic acid. So in the para position to the COH, this is ortho, meta, para. In the para position, we add a amino group, NH2. Now the mechanism of action is it inhibits the synthesis of folic acid by interfering with PABA. And the other one is it inhibits the synthesis of mycobactin. Now this mycobactin is responsible for the ion uptake in the cell walls. The side effects include hepatotoxicity, hepatitis, fever, rashes, that is pruritus, GI, nausea and vomiting. The uses are treatment of multi-drug resistant tuberculosis. So in MDR-TB, we will see para-amino salicylic acid being used. Next we have ethionamide. In ethionamide, we will have ethionamide is very similar to INH. So for reference, we'll draw INH here. So we had a pyridine ring. Attached to this was a C double bond O NH NH2. Now this is your INH. Ethionamide is very similar in its function and structure. Now let us break the word. Ethioamide. So ethioamide. So we'll take a pyridine ring. To this we will add a eth group, that is CH2 CH3, ethyl group right here. And to this thionamide, instead of C double bond O, we will go with C double bond S. And since it's an amide, amide is C double bond O NH2. So instead of that, we will have a C double bond S because it's a thionamide, and then NH2. So this is our ethionamide. Next we have the MOA. So the mechanism of action is the same as INH, that is it will inhibit the synthesis of mycolic acid, which is part of the cell wall. So it will disrupt the cell integrity, cell wall integrity. Next we have the side effects. The side effects will be depression, drowsiness, confusion, hepatotoxicity. Now remember, ethionamide is a part of the second line drugs. Second line drugs have a higher or a much worse side effect profile. So it will affect the nervous system most probably. So in the nervous system, it will cause side effects like depression, drowsiness, confusion, and the common one is hepatotoxicity. The uses of ethionamide are only till anti-tubercular drug. Next we have cycloserine. Now cycloserine is a 5-membered ring with an oxygen in the middle. So we can't call it a furan because there are no double bonds. So in this ring, we will also have a N group attached to it. Next we'll have a oxygen group coming out. Next we will have a NH2 group. So how do we remember this? We will remember on in, on out. So why on in, on out? First we draw a 5-membered ring. So we will keep an oxygen inside, a nitrogen inside the ring. Then we will keep an oxygen outside the ring, a nitrogen outside the ring. So on in, that is inside the ring, these two. On out, that is oxygen outside the ring. So the structure would be on in, on out. So the mechanism of action is it inhibits bacterial cell wall synthesis by inhibiting alanine racemase, which converts D-alanine to L-alanine. Now L-alanine is required for cell wall synthesis. So by inhibiting alanine racemase, it will inhibit the conversion of D-alanine to L-alanine. Now the side effects are anxiety, irritation, depression, mental confusion, hepatotoxicity. The uses are only TB. We also have drugs like fluoroquinolones. Now fluoroquinolones were covered in the other chapter, so I won't be drawing the structures again right here. So fluoroquinolones, we have the mechanism of action is it will inhibit two things. One is DNA gyrase and the second one being topoisomerase 4. So which leads to the DNA disruption. Next we have aminoglycosides. So aminoglycosides will inhibit protein synthesis by inhibiting ribosomal 30S subunit. So there won't be any protein production. Next we have the other second line drugs. In other second line drugs we will use bedaquiline, clofazimine and linezolid. So bedaquiline will inhibit ATP synthase. Now this enzyme is very much responsible for the generation of energy in Mycobacterium tuberculi. So it's a very strong acting drug. It has to be used with caution. Next we have clofazimine. So clofazimine interrupts with DNA synthesis and affects the Mycobacterium DNA. Next we have linezolid. Now linezolid prevents protein translation by binding to the bacteria's 23S RNA of the 50S subunit. So a part of the 50S subunit, that is the 23S rRNA, it will go and bind to, and then it will prevent protein translation. Next we have the management and treatment of tuberculosis. Now there is a question always asked on write a note on treatment of tuberculosis and management of tuberculosis. So first we have to know that there are two types of tuberculosis. One is drug sensitive and one is drug resistant. Drug sensitive as in the drugs can act on the tuberculi bacteria and it will cause the death of the bacteria. Whereas drug resistant is it does not react or does not act towards the drugs. Next, we have in drug resistant tuberculosis, we have 5 subclassifications. That is, in drug resistant, we have monodrug resistant, polydrug resistant, multidrug resistant, extensive drug resistance, and rifampicin resistant TB. Now, monodrug resistant means there is only one drug which it is resistant to, that is INH. Polydrug resistant, now this monodrug resistant are also called H-mono patients, as in the monodrug resistant patients. Then polydrug resistant are they are resistant to any two drugs which is other than INH and rifampicin. Multidrug resistant as in they are resistant to INH and rifampicin. Extensive drug resistance is when they are resistant to INH, rifampicin, and along with this the first line drugs plus fluoroquinolins and aminoglycosides. Rifampicin resistant TB is when they are resistant to rifampicin. Next we have the drug sensitive TB. So for drug sensitive TB, how do we treat it? The duration of treatment would be 6 months. Now 6 months does not mean 30 days. It means only 28 days. Please note this. Next we have two phases in the treatment, the first phase and the second phase. So the first phase is known as the intensive phase. So this intensive phase will go on for 2 months, and the drugs which will be given during this intensive phase is rifampicin, isoniazid, pyrazinamide and ethambutol. Whereas in the second phase, that is the continuous phase, it will go on for 4 months and we will only be giving two drugs, that is rifampicin and isoniazid. Next we have the multi-drug resistant TB. So we have two regimens we can follow in multi-drug resistant TB. That is a long regimen and a short regimen. The long regimen will range for 18 to 20 months. So in this long regimen, we will give 5 drugs. Whereas the short regimen, we have 7 plus 4. So in the short regimen, it will go on for 9 to 11 months. So let's talk about the long regimen. In the long regimen, we will give levofloxacin, linezolid, bedaquiline, cycloserine, clofazimine. Now how can you remember these drugs? These drugs you can remember as CC, LLB. Now CC you can give it your friend's name, and LLB, that is bachelor's in law. So CC, LLB. So CC as in cycloserine, clofazimine, and then LLB is linezolid, levofloxacin and bedaquiline. One more thing you need to notice, linezolid, there should be a dose reduction after 6 months, whereas bedaquiline has to be only given for 6 months out of the 18 to 20 months. Next we have the short regime. In the short regimen, we have two phases, the intensive phase and the continuous phase. In the intensive phase, we have 4 to 6 months of a particular drug, and in the continuous phase, we have 5 months. So, in the intensive phase, we give bedaquiline for 6 months, clofazimine, levofloxacin, pyrazinamide, ethambutol, ethionamide, and a high dose of isoniazid. It is very important to note that there is a high dose of isoniazid here. So how do we remember this? We will take the first line drugs first. Isoniazid, ethambutol, pyrazinamide. So there is no rifampicin in intensive phase of the short regime of drug resistant TB. So INH, ethambutol, pyrazinamide. Then what are the second line drugs? Ethionamide. And from the reserve drugs we have these three, that is bedaquiline, clofazimine, levofloxacin. From the second line we have ethionamide and levofloxacin. And from the reserve drugs we have bedaquiline and clofazimine, these two drugs. In the continuous phase we will use two from the first line drugs, one from the reserve drug and one from the second line drugs. So we'll have pyrazinamide, ethambutol together. The high dose of isoniazid is enough for the intensive phase only. So continuous phase will go with pyrazinamide and ethambutol. From the second line we'll go for levofloxacin, and from the reserve drugs we will go for clofazimine. So that's all we had for today. I hope you all enjoyed the class. I hope you learned a lot about anti-tubercular drugs. So we will come up with such videos on the next topic. That is, for next we will go for antiviral and anti-AIDS agents. I hope you like the class, and if you all have any suggestions for me, please leave them in the comment box. If there are any questions, please leave them in the comment box. I'll get to you as soon as possible. So that's all we had for today. Thanks for listening. Happy studying. Mogasu.